Okay, let's unpack this. We often talk about healthy eating and exercise, right? But there's this third pillar, sleep and rest. It's so vital, but often kind of overlooked.
Yeah, exactly. And it's not just about feeling good yourself. It's critical for health, for recovery, especially in nursing.
Absolutely. So why is sleep really so crucial? And, how does it actually play into the art of nursing itself?
Well, what's fascinating here is our source material. It's a key chapter on sleep and rest from Fundamentals of Nursing, the 11th edition by Potter, Perry, Stockert, and Hall.
Okay.
And it doesn't just list facts. It really digs into why understanding sleep is so foundational. Foundational for patient-centered care, drawing on evidence-based practices, clinical judgment.
Make sense.
So our mission today is basically to pull out those key concepts, the practical stuff, the clinical insights from this chapter, specifically for, well, first you nursing students listening, things you can actually apply.
Great. And to make it real, let's bring in our guiding example, Julie Arnold. She's 51, an attorney, and she's a new patient for family nurse practitioner Susan.
Okay.
Julie got diagnosed with depression last year, and she's really struggling, trouble sleeping, feels tired all the time, can't concentrate at work. It's a lot.
Sounds tough.
Yeah, and she's stopped her daily walks, she's working more hours.
Yeah.
And get this, her 80-year-old mother, Louise, just moved in. Louise is recovering from a hip fracture, and she also has sleep problems.
Oh, wow. So double the challenge.
Exactly. Julie just feels completely overwhelmed. So we'll keep coming back to Julie throughout this deep dive, see how these ideas apply to her situation.
Sounds like a plan. And, to help Julie, Susan, and really all of you, you first need to get a handle on the science behind sleep. It's a cyclical process, right? Alternating with being awake.
Yeah.
And it influences pretty much every biological function and how we behave.
And central to that, I guess, is our circadian rhythm, that 24-hour cycle.
That's the one, your body's internal master clock. There's this tiny part of the brain, the suprachiasmatic nucleus, or SCN, deep in the hypothalamus.
SEM, right?
Yeah, that's a conductor. It controls the rhythm and coordinates it with, everything. Body temp, heart rate, hormones, even your mood.
It's amazing it does all that.
It is. And this clock is surprisingly sensitive. Things like light, temperature, social stuff, work schedules, they all affect it.
Which explains why shift work is so hard, or even just being in a hospital.
Exactly. Those disruptions, they throw everything off kilter. It's not just feeling tired, it messes with appetite, weight, your mental state, anxiety, irritability, even poor judgment. Think about that for a nurse on rotating shifts.
Definitely a safety issue. So what's actually driving this cycle? It can't be just like an on-off switch.
Oh, definitely not. It's complex. We're talking central nervous system activity. The hypothalamus, for example, isn't just the clock. It's a major sleep center. It secretes hypocretins, sometimes called orexins.
Hypocretins.
Yeah, they're important for staying awake and for REM sleep. Then you've got the ascending reticular activating system, the RAS, in the brainstem. Think of it like an alertness system.
Okay, RAS for alertness.
Right. And these work together through two main processes. There's process S that builds up sleep pressure the longer you're awake, influencing how long and deep you sleep.
Process S, sleep pressure.
Got it. And then there's process C, that's the circadian rhythm itself, controlling the timing of sleep. When these two processes interact, that largely dictates when you naturally wake up. The book actually has a figure 43.1, showing process S rising during wakefulness and falling during sleep, and where it intersects with process C determines wake-up time.
Ah, okay. That makes sense. Paints a picture of why timing matters. And sleep isn't just one big block of unconsciousness, is it?
Not at all. It's a journey through different stages, two main types, NREM, or non-rapid eye movement sleep, and REM, rapid eye movement sleep.
NREM and REM.
Right. NREM has 3 stages. N1 is super light, just drifting off. N2 is a bit deeper, but you're still easily woken. N3 is the deepest, what we call slow wave sleep. That's the really restorative stuff.
Slow wave sleep. N3.
Then there's REM sleep. Totally different. That's where you get vivid dreams, your eyes move rapidly, vital signs can fluctuate quite a bit, and your muscles are essentially paralyzed temporarily.
Muscle paralysis?
Right.
Wow. Okay, so how do we cycle through these stages typically?
Well, a full cycle takes about 90 to 110 minutes. And most adults go through maybe 4 to 6 of these cycles a night.
4 to 6 cycles, yeah.
And what's interesting is, as the night goes on, that deep N3 stage gets shorter, and the REM stages actually get longer. Sometimes the last REM period can be up to an hour.
Huh. So why do we actually need all this? What are the big functions of sleep?
Number one is restoration. Especially during that NREM N3 stage, your body slows way down, Heart rate drops, breathing evens out, and importantly, human growth hormone is released.
Growth hormone. For adults, too.
Absolutely. It's crucial for repairing cells, building protein. Basically, physical recovery. Your body literally rebuilds itself.
Okay, physical repair. What about the brain?
That's where REM sleep really shines. It's vital for memory consolidation and cognition, especially important for brain development in infants, but for all of us, it helps strengthen cognitive functions, store memories, and support learning. Blood flow to the brain actually increases during REM.
So REM is like the brain's filing system.
Kind of, yeah. Sorting and storing the day's information.
And when we don't get enough.
Yeah.
Like Julie is experiencing right now.
That's sleep deprivation. And it's a huge issue. Estimates say 50 to 70 million adults in the U.S. are affected. The effects are widespread. Weakened immune system, metabolism changes, mood swings, poor motor skills, memory problems.
Serious stuff.
Very. And chronic sleep loss is linked to major diseases, hypertension, cardiovascular disease, diabetes, obesity, depression. Plus, think about the economic costs from accidents, errors, especially in healthcare. A sleep-deprived nurse, that's a patient safety risk.
Definitely. What about dreams? Are they just random noise or do they do something?
Well, you dream in both NREM and REM, but REM dreams are the really vivid, story-like ones. Theories suggest they might help with learning, processing memories, maybe even adapting to stress. Sometimes analyzing dreams can even be therapeutically useful.
Interesting. Okay, so beyond the basics, what else really messes with our sleep? Physical illness must be a big one.
Oh, huge. Pain, discomfort, anxiety, depression linked to illness, they almost always disrupt sleep. Think about respiratory problems like COPD or asthma. You might need to sleep sitting up.
Or heart disease.
Right. Things like nocturnal angina, even common issues like nocturia, having to get up frequently to urinate, can severely fragment sleep. Very common in older adults or people with diabetes or heart issues.
And you mentioned restless leg syndrome. RLS.
Yes, RLS. It's this overwhelming urge to move your legs, often with a creepy, crawly, or itching feeling. Moving is the only thing that brings relief, so falling asleep is incredibly difficult. It's more common in women, older adults, and sometimes linked to things like iron deficiency.
What about stomach problems? Gastrointestinal issues?
Yeah, definitely. Things like peptic ulcers, GERD, or even IBS are often linked with disrupted sleep. Acid reflux tends to be worse when lying down, for example.
Which naturally leads us into specific sleep disorders. Insomnia seems like the most common one people talk about.
It is. Affects maybe up to 30% of adults. It's that chronic difficulty falling asleep, staying asleep, or just feeling like your sleep wasn't refreshing. Often tied to depression or, frankly, just bad sleep habits, poor sleep hygiene.
Then there's sleep apnea. That sounds pretty scary, stopping breathing while you sleep.
It is scary and serious. You stop breathing for 10 seconds, maybe up to a minute or two, repeatedly through the night. The most common type is obstructive sleep apnea, or OSA. That's where the throat muscles relax too much, blocking the airway. Loud snoring is a classic sign.
Any other type?
Central Sleep Apnea, CSA, that's less common. It's more of a brain issue. The respiratory control center just doesn't send the right signals to breathe.
But the symptoms are similar.
Often, yes. Excessive daytime sleepiness, or EDS, is huge for both. Fatigue, morning headaches, irritability, depression, and untreated apnea, big risks. Hypertension, diabetes, heart problems, even stroke.
So treatment is crucial. Things like CPAP machines.
Yes, CPAP or BPAP machines are common, along with lifestyle changes like losing weight, improving sleep hygiene. Sometimes surgery or oral appliances are options too.
Okay, another one you mentioned was narcolepsy. That's the one with sudden sleep attacks.
Exactly. It's a dysfunction in how the brain regulates sleep and wakefulness. The main symptom is that profound, excessive daytime sleepiness, sometimes leading to these sudden, irresistible urges to sleep, often falling right into REM sleep within minutes.
And there's that other symptom, cataplexy.
Yes, cataplexy. It's quite unique to narcolepsy. It's a sudden loss of muscle tone, triggered by strong emotions like laughter, surprise, or anger. Someone might just collapse, but they're still conscious.
Wow. That must be difficult to live with.
It really can be. Other symptoms can include really vivid dreams as you fall asleep, and sleep paralysis, that feeling of being unable to move right before falling asleep or waking up.
Is there a cure?
No cure. But treatments help manage symptoms. Stimulants like modafinil, sometimes certain antidepressants, plus lifestyle things, scheduled naps, good sleep habits, regular exercise.
Then there's just general sleep deprivation, which isn't a specific disorder like apnea or narcolepsy, but just not getting enough sleep.
Right. Insufficient or disrupted sleep, either short-term or chronic, can be caused by illness, stress, medications, noisy environments like a hospital, or shift work. We see the effects physically: clumsiness, blurred vision, maybe even cardiac arrhythmias, and psychologically confusion, irritability, lack of motivation. This is a big part of what Julie's facing. The book lists physiological and psychological symptoms in box 43.3.
And the treatment is basically...
Find the cause and fix it, if possible. Manage the environment, adjust patient care routines in the hospital.
What about parasomnias? You mentioned those are more common in kids.
Yes, things like sleepwalking, night terrors, nightmares, bedwetting, even teeth grinding, or bruxism. Most kids grow out of them. Also, critically, SID's sudden infant death syndrome falls under this discussion, reinforcing the back-to-sleep supine position recommendation from the AAP.
So beyond these specific problems, our basic sleep needs change as we age.
Right, dramatically. Newborns sleep around 16 hours a day, about half of it in REM sleep, crucial for brain development. Infants still sleep a lot, around 15 hours. Toddlers drop to about 12 hours and usually give up naps by age 3.
Preschoolers?
Still around 12 hours at night. Bedtime fears and nightmares are pretty common then. School-age kids need maybe 9-12 hours depending on age.
And adolescents.
Oh,
That
same.
seems to be where problems often start.
Often, yeah. They really need 8-10 hours, but with school schedules, social lives, phones, many get 7 hours or less. This leads to that excessive daytime sleepiness, contributes to obesity risk, accidents, mood issues.
What about adults, young adults?
They average maybe 6 to 8.5 hours. Stress from jobs, starting families, that can cause issues. Pregnancy also impacts sleep, increased need, hormone shifts, nocturia, sometimes RLS.
Middle age, like Julie.
Often a decline in that deep NREM stage 34 sleep. Insomnia becomes more common, often related to stress, maybe menopause for women.
And older adults.
Yeah.
Like Julie's mother, Louise.
Yeah, sleep changes significantly. About 40% report problems. They tend to have more light sleep, less deep sleep, less REM, wake up more often. Napping might increase. Chronic illness, medications, sensory impairments, CNS changes all play a role. Increased risk for falls if they get up at night.
You mentioned medications. That seems like a huge factor across the board.
Absolutely. So many drugs and substances affect sleep. Box 43.4 in the text list, quite a few. Hypnotics might help you fall asleep, but can reduce deep sleep or REM.
Right.
Antidepressants, stimulants can suppress REM. Alcohol might make you drowsy initially, but it severely fragments sleep later in the night. Caffeine, obviously, is a stimulant. Even things like diuretics making you wake up to pee, beta blockers causing nightmares, nicotine. Lots to consider.
So nurses really need to review medications carefully.
Definitely. And then there's lifestyle. Rotating shifts, as we said. Even just late-night social events or changing meal times can throw things off. And technology. That blue light from phones and tablets before bed really messes with melatonin production.
Emotional stress, too. Worry, tension. It keeps the mind racing, making sleep impossible. We see that clearly with Julie: work stress, caregiver stress.
Exactly. And environment. Is the room too hot, too cold, too noisy? Is the bed comfortable? Even sleeping with a partner can be disruptive sometimes. Hospital noise is notoriously bad.
Okay, what about exercise and fatigue?
It's a balance. Moderate fatigue helps you sleep. Getting regular exercise, especially morning or afternoon, is great for sleep. But doing intense exercise right before bed can actually be too stimulating. And being utterly exhausted can sometimes make it harder to fall asleep too.
And food and caloric intake.
Big meals, spicy food close to bedtime can cause indigestion. Caffeine, alcohol, nicotine in the evening, definitely disruptive. Weight gain is a major risk factor for sleep apnea.
Okay, this is a lot of information. Which brings us to the really crucial part for our listeners, the nursing process in sleep management. How do nurses actually use all this knowledge?
Right. It's about critical thinking and clinical judgment. You're synthesizing everything: the physiology, the potential problems, medications, the patient's unique situation, your experience to make good decisions. Figure 43.2 in the text shows the cycle. Assessment, diagnosis, planning, implementation, evaluation. It's core nursing practice.
So let's walk through that with Susan and Julie, starting with assessment. It always begins through the patient's eyes, right?
Right. Always. Sleep is subjective. Only Julie knows if she feels rested. So Susan needs to ask detailed questions about her experience. Sometimes asking a bed partner can give clues too, about snoring or pauses in breathing, for example.
Are there specific tools nurses use?
Yes. Like the Epworth Sleepiness Scale. It's 8 questions asking how likely you are to doze off in different situations. gives a score, helps quantify daytime sleepiness. There's also the Pittsburgh Sleep Quality Index, and sometimes a simple visual analog scale, just a line from best sleep to worst sleep, is great for tracking changes over time.
And the sleep history itself. What kinds of questions?
You dig deep if there's a problem. What's the nature of it? Signs, symptoms, when did it start, how bad is it, what makes it worse or better, what effect is it having? The book has great examples in box 43.5 and 43.6 for specific issues like apnea or narcolepsy. Sometimes a sleep-wake log for a few weeks is really helpful, and tools like the Stop You Bang questionnaire screen for OSA risk.
You also need to know their usual sleep pattern to see what's changed.
Exactly, and assess for physical and psychological illness, chronic conditions, medications, especially polypharmacy in older adults, psychiatric history. Julie's depression is key here.
Current life events, Julie's job stress, caregiver role, those are huge.
Absolutely, and her emotional and mental status. Anxiety, stress, often treating the underlying emotional issue helps the sleep. Assessing bedtime routines, what does she do before bed? And the bedtime environment noise, light, electronics.
And finally, observing behaviors of sleep deprivation.
Yes. Irritability, yawning, maybe slurred speech, poor concentration. Susan saw several of these in Julie. Dark circles, tears, elevated vitals. It all paints a picture. Julie admitted to late nights, coffee, wine, worrying, stopping exercise, and Louise's situation clearly adds to it.
So after gathering all that data, it's analysis and nursing diagnosis.
Right, you cluster the cues, one finding isn't enough. For Julie, the priority diagnosis jumps out, impaired sleep.
Makes sense.
But Susan also identified related factors. Fatigue, obviously. Caregiver stress, definitely. And because Julie stopped walking, impaired health maintenance. They're all interconnected, linked to her depression and stress.
Okay, diagnosis established, then comes planning and outcomes identification.
This is where you collaborate with the patient. Set achievable, patient-centered goals. Consider their preferences, culture. For Julie, outcomes might be reports waking less often and feeling rested within 4 weeks, or verbalizes using a consistent bedtime routine within 4 weeks. Figure 43.3 shows a nice model for this planning phase.
The book also has a concept map, figure 43.4, showing how Julie's nursing diagnoses link to her medical diagnosis and stress.
Yes, it visually connects impaired sleep, caregiver stress, fatigue, impaired health maintenance to her depression. It helps prioritize. Often you tackle the physical symptoms interfering with sleep first. Teamwork is key too, involving the patient, family, maybe referring to specialists.
So Susan's plan focused on tackling the sleep and stress, helping with Louise, and respecting Julie's preferences. Now, implementation, the doing part.
Exactly. Interventions often focus on health promotion, especially in community or home settings. Box 43.9 has a great list of sleep hygiene techniques.
This sounds like the really practical advice.
It is. Things like exercise daily, but not too close to bed. Avoid long weekend sleep-ins. Use the bedroom only for sleep and sex. No TV, no studying. Try relaxation instead of worrying. If you're not asleep in maybe 20-30 minutes, get up, do something quiet, then try again.
And the usual suspects, limit caffeine, alcohol, turn off screens.
Definitely. At least 30 minutes before bed for screens. Maybe use earplugs or an eye mask. Avoid heavy meals within 3 hours of bed. A light snack might be okay.
What about environmental controls?
Make the room comfortable, temperature, ventilation, minimal noise, a comfortable bed, proper lighting, maybe a soft night light for older adults or kids. And again, limit that blue light from devices in the bedroom. For infants, safety is paramount. Always supine, firm mattress, fitted sheet, no pillows, no loose blankets, no toys in the crib.
And promoting bedtime routines.
Consistency is key. For kids, same time each night. Maybe a snack, bath, story, cuddle. For adults, wind down time. Avoid stimulating activities. Light reading, calm music, relaxation exercises like deep breathing or guided imagery can help. Associate the bedroom with sleep.
What about promoting safety?
Especially for older adults or those at risk of falls. Night lights, clear pathways, maybe lower the bed. For sleepwalkers, don't startle them, just gently guide them back to bed. Infant safety we mentioned, back to sleep, clear crib.
And promoting comfort.
Simple things matter. Good hygiene, maybe a warm bath, loose nightwear, enough blankets, emptying the bladder before bed, positioning patients comfortably, especially if they have pressure injury risks. Figure 43.5 shows good positioning. Removing irritants like wet dressings.
In the acute care setting, like a hospital,
Yeah.
how do you establish rest periods? It seems so hard with all the interruptions.
It's challenging, but vital. Nurses need to control the environment. Dim lights, closed doors, minimize noise. Box 43.12 has tips for hospitals. And crucially, cluster care. Combine necessary tasks like vital signs, meds, assessments to allow for uninterrupted blocks of sleep, ideally 2-3 hours. Be an advocate, question non-essential nighttime disturbances.
Stress reduction techniques.
Encourage patients not to try so hard to sleep. If anxious, get up, do something relaxing. For kids' fears, provide comfort, reassurance, maybe a nightlight, but guide them back to their own bed. And be culturally aware. Box 43.1 discusses co-sleeping bed sharing. Understand the cultural context, but always discuss SI's risks.
What about bedtime snacks? Does warm milk actually work?
It might. Milk contains L-tryptophan, which can promote sleepiness. Warm milk or cocoa can be comforting. Just avoid sugary snacks or caffeine. And no bottles in bed for infants' risk of tooth decay.
Okay, then there are the pharmacological approaches.
Right.
The medications.
Yes. Melatonin is a popular supplement, a neurohormone, often helpful, especially for older adults, generally safe short-term. Doses like 0.3 to 3 milligrams a couple of hours before bed are typical.
Herbal products, like valerian.
Valerian, lavender, passion flower, chamomile. Some people find them helpful for mild insomnia. But caution is needed. They aren't FDA regulated and can interact with other medications. Always ask patients about herbal use.
What about non-prescription sleep meds? Over-the-counter stuff.
Generally not recommended for long-term use. They often contain antihistamines, which can cause side effects like confusion, constipation, urinary retention, especially problematic in older adults, increases fall risk.
And prescription meds. Hypnotic sedatives.
These require careful consideration. The FDA has warnings about potential side effects like allergic reactions or complex sleep behaviors, sleepwalking, sleep driving.
Benzodiazepines.
Benzos and the newer benzodiazepine-like drugs, like zolpidem, are often used for short-term insomnia. The newer ones are generally considered safer. Benzos themselves can cause relaxation and reduce anxiety, but carry risks, especially in older adults. Prolonged effects, respiratory depression, next-day drowsiness, memory issues, rebound insomnia, increased fall risk. Definitely not for infants or pregnant breastfeeding women.
Any alternatives?
Trazodone, an antidepressant, is sometimes used off-label for insomnia, especially if there's also depression or anxiety. But the key takeaway is try non-pharmacological approaches first. Meds should be a last resort or short-term solution.
So putting it all together for Julie, what did Susan actually do?
She discussed sleep hygiene, sticking to a schedule, using the bedroom only for sleep, suggested a warm bath, a daily 30-minute morning walk, using soft music, and taught relaxation techniques. Advised getting out of bed if awake after 20 minutes. No heavy meals, caffeine, or alcohol within 3 hours of bed. Keep the bedroom cooler. Use a sleep log.
What about for her mother, Louise?
Similar idea, soft music, checking the environment, maybe short naps, but no more than 30 minutes. Susan also provided resources, caregiver support group info, home health services options. Really holistic.
Okay, final step. Evaluation. How do you know if the plan worked?
Again, through the patient's eyes. Ask Julie, are you feeling more rested? Did those relaxation techniques help? Which changes made the biggest difference? Her perception is key.
And you compare patient outcomes to the baseline.
Exactly.
Yeah.
Did she meet the goals we set? Observe things like how quickly she falls asleep, how often she wakes up. Use those assessment tools again, like the visual analog scale. And use teachback to make sure she understands the plan going forward.
So how did Julie do at her follow-up?
Really well. Susan used teachback. Julie reported sleeping much better, only waking once, getting about 7 hours. She'd started walking again, felt less stressed. Her blood pressure and pulse were down. She'd used the suggestions for her mom, who's also doing better, and she'd contacted home care. She was even thinking about the support group.
That's fantastic. A real success story showing the nursing process in action.
It really is. Collaboration, assessment, planning, intervention, and follow-up. It ties directly back to those core nursing competencies.
So wrapping this up, what does this all mean for you listening, whether you're a student, a practicing nurse, or maybe just someone wanting better sleep? It means understanding sleep isn't just about counting sheep, is it?
Not at all.
It's about unlocking this incredibly powerful lever for health, for healing, for resilience, both for ourselves and for the people we care for. Maybe think about this. How might getting a deeper understanding of your own sleep patterns or those of your family actually transform your daily life?
And if we connect this back to the big picture for nurses, mastering sleep assessment and intervention, it's not just about exams like the NCLEX. It's fundamental to providing truly holistic, patient-centered care, no matter where you practice.
Oh. Absolutely. We really hope this deep dive has given you some valuable insights and practical strategies you can use. Thank you so much for joining us on this learning journey as part of the Deep Dive team. Keep exploring, keep learning, and keep making a difference, one rested patient at a time.